today is a general introduction to dual energy CT. It's a lot to cover over an hour, so the hope is we'll do a very broad overview, and then over the next months, and we can do this as long as you guys want, we're going to have multiple topics on dual energy CT, specifically with certain niche applications. So with that, I'll go and get started. If you guys have any questions, just let me know. If you guys can't hear me on the phone, just speak up and I'll try to talk louder. For those of you that I haven't met, I look forward to working with you as the months and years come along. These are my disclosures. So if you look at dual energy CT, it is not a new technology. This is Sir Godfrey Hounsfield back in 1973 describing dual energy CT. He's essentially saying, if you take two pictures, one at 100 kV and another at 140 kV, and if the atomic numbers are high enough, you can actually differentiate iodine and calcium. Okay, so dual energy CT is not technically a new technology. And this is the outline that I'm going to try to cover over the next 15 minutes or so. So basic principles, just to kind of give you a background on how it works, the different platforms that are out there, focus a lot of time on the clinical use and the value. I'm not going to go over limitations and challenges again for time's sake, and then I'll flip it over to Leor for about 5 to 7 minutes for some workflow stuff. So let's talk about some basic principles of dual energy CT. How does it work? Well, any talk about CT has to have a talk about physics, so bear with me, okay? There are basically two primary ways that photons interact when we're talking about diagnostic imaging, okay? So we're talking about Compton or inherent scattering, which is what you see here, and in this case, you basically eject a weakly bound outer electron. All you need to know is Compton scattering is one of two ways where you have X-ray interaction, but this is not that contributory. The more important one is the photoelectric effect, okay, which is this one here. You basically get an incident photon. It basically vacates a K-shell, and you get an X-ray generated. And this is the important interaction. As I mentioned, both the photoelectric effect and the Compton scatter are responsible for the total attenuation in soft tissue. So this is attenuation against energy. The probability of Compton interaction really, it's just dependent on the electron density. It really provides little contrast. So again, that's the one that you really don't need to focus on. But the photoelectric effect is highly dependent on the atomic number. It's also dependent on the K-shell electron binding energy, and that's why we talk a lot about K-edge of certain material. It's the primary mode of interaction in substances with a high atomic number, i.e. iodine. So if we give iodine to somebody and we want to use X-rays, this is the effect that's going to help us see it. This is the one that's responsible for its attenuation. So why do I bring all this up? Well, this is what's going to let us understand how dual energy CT works. Here, I've graphed mean attenuation coefficient versus energy, so just attenuation versus energy. And this is how iodine behaves. It has a low attenuation as you go up in energy. It spikes at its K-edge, which is about 33.2, and then it goes a little bit down and then back up, okay? But it spikes at 33.2. So this is when the photon that's coming incident to the iodine's atom, and it's basically at the same level as the K-edge. That's something we know in physics, that you get this massive spike in attenuation, and this is going to be important here in a second. But what this shows is that the photoelectric effect is energy dependent, okay? And the K-edge for each element varies. So because the attenuation, which is primarily by photoelectric effect, varies based on the energy that you use, and because the energy, or the K-edge, is also variable based on the atomic number, i.e. calcium's 4, iodine's 33.2, this forms the basis of dual energy CT, okay? So just a little physics about how you get dual energy CT and what the physics are behind it. So let me show you this graph too, okay? Here you've got two materials. You've got iodine in this solid white line and calcium in this dotted line, okay? And if you look at its attenuation, which is this symbol here, it's dependent on three things: the energy at which you image, the atomic number, and the density. Well, let's say you're imaging at a given energy. So let's say we're imaging at 80 to 120 keV, or in this case, let's say we're imaging at 120 kVp, okay? So you get a fixed energy. Well, iodine and calcium have a different atomic number. And in this case, they have a similar density, but because they have a different atomic number, you can see that their attenuation is different. Does that make sense? Mm-hmm. So different atomic number, same density, at a given energy, different attenuation. But this is not real life. In the human tissue, you can vary the density of iodine such that despite it having a different atomic number and you're imaging at a given energy level, the attenuation is similar. This is where we struggle. faint calcium and really dense iodine can look very similar. How do you tell those two apart? Well, if you're at a single energy, you're done. Because the density we can't do anything about. The atomic number we can't do anything about. You've already scanned at that energy. But with dual energy, you've scanned at a second energy level. And therefore, you can still separate them. So this is the benefit. You can separate things where at single energy CT, you may not be able to because you've gotten an additional piece of information. Okay? So a lot of physics, a lot of graphical stuff, but that's just to kind of give you a little orientation and maybe a little taster of it. These basic principles and the physics properties are behind what dual energy CT can do, okay? And so what is the value proposition? You can do material characterization, iodine, fat, iron. You can decrease dose, that's both radiation dose and contrast media. And you can also improve image quality. I got that in bigger letters on purpose because that's where a lot of the mainstay is, optimization of the iodine contrast and CT artifact reduction. Just yesterday, we saw a case where we didn't have the contrast timing optimized, but it was a dual energy scan, and it prevented that patient from having to be injected and re-imaged because we were able to use the low KEV images to really bring out the iodine contrast, okay? Here are the common myths about dual energy CT, okay? And this is what I hope to basically debunk, not only today, but over the months and years to come. Dual energy CT has double the radiation dose. This is not true, okay? Yes, when we used to scan in dual energy mode, which is you put the patient through the scanner once, let's say at 120 kVp or 140 kVp, and then you back up and you scan them again a second time, of course, that's double the dose. But you'll see with the current techniques that it's not double the dose, and I'll get into this. I can already see some people saying that doesn't make sense to me. Dual energy CT takes a longer time to scan, not true. Should be roughly about the same as a single energy scan. You guys will give us input on that, whether that's true or not. Love to hear from you guys. Dual energy CT costs more in terms of the amount that we bill. Not true. In fact, I'll show you that it actually, to the public society, saves a lot more dollars in terms of the things that we can do with it. Dual energy CT image quality is poor. Yeah, early on, the image quality was not great. We learned a lot. This is not a new technology. We're still adopting it. But early on, it was plagued by a poor image quality. The radiation dose is a little bit higher, but we've sort of learned so much that we've optimized it where none of these things are actually true, and I'll go over all this. All right, so let's talk about the different platforms, okay? You can scan for dual energy in a variety of ways. So on the far left, this is a dual source scanner. This is going to be your Siemens, okay? Your flash and force mainly that you need to worry about. It has two sources, one source, second source, and two detectors. That's fitted in one gantry. You can also do consecutive scan. This is old school. Don't worry about that. You could split the filter, or you can do a split filter and have a twin beam technology. Again, old school, don't worry about that. So this is the main way Siemens scans, is the only way Siemens scans. Now, Siemens actually started with a KV switching, but then they went to the dual source. The KV switching is what GE does. You have one source, one detector, and it rapidly goes between a high energy and a low energy. The typical traditional high energy and low energy is 140 kVp and 80 kVp. That's changed a little for the Siemens, but just keep that in mind, 140 kVp, 80 kVp. The other is the Philips Icon, which is a dual layer technology. Single X-ray tube, but you have two detectors and they're layered. So one detector detects energy at low levels, the other is a high energy detecting detector. This one has some limitations in that the spectral separation isn't as great, as you'll hear more and more about spectral separation. The good thing about this is everybody technically is scanning dual energy, right? Because it's one source, one detector, even though that detector is two layers. So that is its advantage. We're going to focus on the ones that we have here. These are our scanners at Stanford. We've got two Siemens, a second generation and a third generation, the Flash and the Force. We have a second generation and a third generation GE, okay, a 750 HD and the Revolution. And then we're going to get two Forces at the hospital and additional Revolution in 2019 with 500p. Okay, so we have some great capital here. All right, and these are our second and third generation dual energy scanners. They're great. Let me just tell you what we've done already and the amount of work that's already been put into place. This is the roadmap that I had in my head when I first started in August, okay? That we would basically start with the Revolution CT since it's at an outpatient center and sort of work our way in, okay? We learn from it, basically do some QA, QC, get the IT stuff going, make sure that the workflow is optimized, then maybe start with a Force at the Sherman, then finally get to the Flash, and then hopefully the implementation is complete at some point by February to March of 2018. Well, we're pretty much nearly done with implementing dual energy CT on the Flash. I think that'll be done by mid-February, so we are well ahead of schedule. I told you that one of the things that, we do some things better than other institutions, adoption. right? This is an incredible timeline. I mean, if you show this to anybody around the country, it's hard to get even one scanner scanning in dual energy mode with all the protocols in several months. We've managed to do a number of our scanners in far less than 6 months, and that's a tribute to everybody in this room, everybody on the line, and to Christoph and Lior's help as well, okay? So this is certainly a team effort, and I appreciate that. These are the protocols that we scan in dual energy mode at Duke. So it typically, folks say, look, the value is in multiphasic acquisition, so in the arterial phase where you really can increase the conspicuity. So you see RCC, dual liver, dual pain, GU, mesenteric ischemia, CT. You see the theme here? They're multiphasic, they have an arterial acquisition, so you want to try to increase the conspicuity. My philosophy is, if you believe in dual energy CT, you better do it on everything. Either you believe it or you don't. Either it adds value or it doesn't. If it adds value in one phase, why wouldn't it add value in the portal venous in the delayed phase? So our advantage at Stanford is we do dual energy CT in every single phase, arterial, portal venous, even the renal delays. And there are clinical and research applications for doing so. And everything we do isn't just to do it for the purpose of doing it. It has downstream effects, clinical care and research applications. Okay, so I might not be able to articulate all those points today given our time limitation, but that is true. So really quickly, just a little bit about both vendors. With Siemens, the dual source dual energy CT, again, I said there, this is basically one gantry. It has 2 tubes and 2 detectors, okay, and they're offset about 90 degrees. It has several advantages. You can do 2 current modulation mainly, and you can increase the spectral separation by applying a tin filter. I'll get into this in a minute. But the main advantage of this that you should keep in your head is we can 2 current modulate, okay, because you got 2 independent tubes and 2 detectors. It has some disadvantages like anything would, okay? Here's basically the flash scanner, and you can see this is detector B or tube B. Here's tube A and detector A. So this is actually smaller, this tube and detector, than tube A. And you have to make it smaller, because how do you fit all that hardware into one gantry, okay? And they're also offset, as I mentioned, 90 degrees. And what that does is that creates sometimes some cross-scattering of x-rays. But the main thing is it creates this limited field of view. So the only time you can have dual energy is when both of these tubes are overlapping, right? A low energy and a high energy. So when you're scanning in low energy and high energy simultaneously, that's where you have overlap, and that's the dual energy field of view. Because one of the tubes is smaller, because you have to fit it in one gantry, that means you've got a limited dual energy CT field of view. That limitation is basically based on whatever the small tube covers, okay? So it's 26 centimeters on the flash, 33 on, 26 on the definition, 33 on the flash, and then 36 on the force, which you'll see here. What does that mean? That means everything outside of that dual energy field of view is scanned in single energy, and it's scanned at the low kVp, okay? So 80 or 90 or 100, depending on what we choose. So this is actually critical, okay? So this is why centering becomes important. I'll show you a case of that. But I want you guys to understand that because you have 2 different tubes and 2 different sources, which is great because you can 2 current modulate. But that also means that the only time you get dual energy is where those 2 overlap. And if you take that area of overlap, okay, which is this, and you go in a circle, it creates this limited field of view, and that's why we have that. And then the question is, well, how come one of them has 26, one of them has 33, and one of them has 36, right? How did they increase it? They were able to increase the angular offset. Okay, so if you look here, that angle's 90. They increase it ever so slightly. When you do that, it comes at a cost, so they can only do it incrementally, okay? Cross-scatter becomes an issue. So if you can increase that angle, you can increase the dual energy field of view. This is what happens, okay? If we don't center the patient correctly, you got to really keep in mind, what are we scanning, okay? What do we really want to keep within the dual energy field of view? For the most part, it's everything within the peritoneal cavity, right? All your solid organs. But occasionally, it may be that a patient has something in their skin. Maybe they have a tumor in the skin, and that's exactly what we need to image. So sometimes it does require us to figure out, okay, what is the clinical question, and let's scan appropriately so we're covered in the dual energy field of view. This is an iodine overlay. You can only get iodine overlay for those areas that you scan in dual energy. Otherwise, everything outside of this dual energy scan field of view is single energy. So you can see a clear circular demarcation. I don't know if you guys are able to appreciate that on the projector. But you can see that there's this nice demarcation between where the iodine starts and the iodine starts and stops, right? And everything scanned here is with the lower kVp, okay? So here we can't get any dual energy CT information. Moreover, the image quality isn't great. You guys stop me if that doesn't make sense. This is the other vendor we have, GE, which does rapid KV switching. Okay, it switches back and forth between 80 and 140. It's dynamic switching. It has this nice scintillated crystal in its detector, so it can rapidly, it has basically a faster speed of light emission. All that means is because it goes really quickly from 80 and 140, the detector can accommodate that. The advantage is you get the full field of view, 50 centimeters. You're not limited because you don't have two tubes. You have one tube that just goes back and forth. And because of that, that sort of field of view limitation is gone. What are the disadvantages? Well, we'll get to that in a second here, but one of the things, as I mentioned, is it has to go from 80 kVp to 140 kVp. And though it does it really fast, it still has to ramp up and down. And until the new tube comes out, you can't tube current modulate, right? Because you got to go rapidly between 80 and 140. If you try to tube current modulate, that tube is going to burn. All right, it's just not possible. Now, with the newer tube, that's supposedly possible, but the MA, the current output is still not going to be as high as having an independent tube. All right, what does dual energy CT do? It allows us to create these synthetic images, virtual monoenergetic images, okay? So if you look here, this is an 80 kVp image, this is a 140 kVp image. Notice around these, this is a phantom basically. Notice all this beam hardening that you see around both of them, okay? But what we can do is take the data, and I'm going to spare you the physics, but we can take the projection data and make monoenergetic images, okay? So when we scan, we're scanning polychromatic, KVP. But what we can do when we scan with two different energy is create monochromatic or monoenergetic, meaning it's a single 40 keV, 50 keV, 60 keV, 70 keV. It's an ideal X-ray beam, right? So polychromatic, when you scan with 120 keVp, it's not that everything is 120 keV. In fact, the average keV of that 120 keVp beam is 77. You get some that are 70, you get some that are 140, 150, but the average is 77. But with this technology, you can create monoenergetic beams. And what that allows us to do, how that translates in image quality is we can reduce beam hardening, we can play around with meta artifact reduction, and really optimize image quality in terms of enhancing the contrast, okay? The name of the game is spectral separation. The further you can separate your two high and low energies, the better. It gives us better information. We can do better material decomposition. We can reduce noise, okay? So if we could do, 50 kVp and like 160 kVp, that would be great. That's a huge separation, okay? But as it stands, most, the traditional two energy pairs are 80, 140, okay? There's always trade-offs. You can't go too low and you can't go too high. So 80, 140 happens to be what we scan with, okay? So you say, okay, 80, 140, that's great. You get a 60 keV difference. But no, remember, when we're scanning 80 kVp with a polychromatic beam and 140 kVp with a polychromatic beam, there's a lot of overlap, right? Remember, 80 kVp means that some of the photons are at 50, some are at 80, but the mean probably is around 55, 60. 140 kVp, the mean is probably around 90 or so. So there's a lot of overlap. It's not that nice separation. And in fact, the real separation is about 30, not 60 kV. Okay? So everything we try to do is try to separate the high and low energy. The better separation you can get, the better your dose efficiency, the better your material decomposition, the better you can quantify things like iodine. So one of the ways we can do that is what Siemens does, which is they apply a little 10 filter distal to the bow tie. And what that does is just separates out, it just moves this 140 kVp curve a little bit to the right, okay? And what that means is, traditionally you have less overlap when you apply that 10 filter, so you get about a separation of 50 instead of 30. So just keep that in mind. You're going to see with Siemens scanners, you see, 80 and 140 SN. Well, what is that SN? That SN is that 10 filter. It allows you just to increase that separation. So what are the key points? You want to get as much separation as possible. Hard to do with polychromatic beams. One way Siemens does it is it applies a little 10 filter just to increase the separation. The nice advantage of increasing that separation is the low energy, we can bump this 80 kVp up to 90 kVp or 100 kVp, okay? So Siemens actually allows you to play around with the tube pairing. So again, traditionally it's 80, 140, that's what GE lets you do and that's fixed. But with Siemens, because you've got this 10 filter, you can bump up the low tube voltage up to 100. The new scanner, the 4 scanner, you can actually go down to 70, choose 80, 90, or 100, and the high tube voltage is 150. This gives us great spectral separation, but think about the low tube voltage. The medium and obese patients, they're no longer an issue, okay, because you can bump up the KVP on that low tube. So I bored you with all the physics and how it works. But, you know, part of that, it's not that you're going to remember it. Maybe some of you guys already know about it, but you have to know some of it. The basic principles, right? I mean, not everybody knows how a car works, but we know the basic premise, right? Turn the ignition, needs the fuel, there's a process. So I wanted you guys to at least see the dual energy CT and how it works, okay? So let's talk about some clinical applications. How is this thing helpful, all right? So here's some of the key points. Increased lesion conspicuity, improved lesion characterization, but the main thing is it makes CT quantitative. I'm not the guy that's going to tell you CT is not quantitative and MR is quantitative. No way. CT is quantitative, and dual energy allows CT to be quantitative. And when you have these three things, you can improve the care that we give to our patients, oncologic and even non-oncologic, even though it just says oncologic. So let's just take these one step at a time. Increased lesion conspicuity. You're going to have to forgive the projector here, okay, but you'll see some better examples. As I mentioned, you can play around with the virtual monoenergetic images. In other words, the low KEV, high KEV. You can generate these images, okay? Typically, right now, what we do is we're creating a low KEV that's 50 KEV, and then we create a high KEV that's 70 KEV. We could change that. We could do 75 and 40, 78 and 50. We could do a number of combinations. But you have to be careful. As we go up high towards the KEV, we know a couple of things. Beam hardening goes down. But as your noise goes down and your beam hardening goes down, so does your contrast. Well, what if we go the other way? Well, if we go towards a low KEV, it's great. We're going towards the K edge of iodine, right? You're going towards that 33.2. So the iodine contrast increases. That's awesome. But when your contrast increases this way, so does your noise. If you can see, this image is quite noisy. So we have to basically find a little balance in that trade-off. But this is what we see often. Okay, this is a 57-year-old female, weight loss and painless jaundice. This is a single energy equivalent exam that shows a pancreatic tumor. Without that arrow, it would be hard to see the tumor. Okay, where is that tumor? Well, here's a stent. This is pancreas. This is duodenum. There is this tumor right here. All right, hard to see. Why is this important? Well, obviously, you want to be able to see it to make the diagnosis, but we pretty much knew she had a pancreatic cancer because of her symptoms, and she's got a stent in place. But how do you get a size measurement on this thing? How do we know what size it is? Because that affects staging. If we can't see it, how do we follow it once the patient gets treated, right? There are a lot of implications to being able to see the thing well. This is where dual energy can be helpful. If we take the same set of images, and here you don't see it well, if we take a 50 KeV, I hope you can see that this is a little bit more obvious here than it is here, okay? So as we go towards a lower energy images, your contrast increases. Also a little bit noisier, but that's okay. There's always a trade-off between contrast and noise. Contrast is higher, so is the noise, but you can see the lesion conspicuity better here. This is the added value of dual energy CT, these images. These are the iodine-only images. With GE, you get iodine-only images. With Siemens, straight off the server, you'll get iodine overlays. What this does is basically the algorithm looks at every single voxel and says, let me see how this little whatever material is behaving. If it behaves like iodine, I'm going to make it bright on these iodine images. If it doesn't behave like iodine, let's say it behaves like water, I'm going to make it dark. Okay, it's a very crude way of explaining it. But essentially what you should know is if it contains iodine, the algorithm makes it bright. Look at the aorta, really bright. Kidney, cortex, really bright because it contains iodine. The tumor, pancreatic cancer, is traditionally not a vascular tumor, so it's dark, right? So the algorithm does not make it bright. But the pancreas, normal pancreas should enhance. That's why it makes the pancreas brighter. So what we've effectively done is increase the lesion conspicuity. We maximize the iodinated contrast. Normal pancreatic parenchyma should be bright because it has iodine in it. All right, so we're going to do that. The adenocarcinoma, the hypovascular tumor, is normally dark, so we're going to downplay that, and therefore you increase the lesion conspicuity. Same thing can be said about this case. This is a patient who has a pancreatic cancer in the tail, better seen on these low KeV images. I hope you guys can appreciate that. Again, it's a little bit noisier. But just notice even the contrast in the aorta and the kidneys. Again, this tumor stands out a lot better here than it does here. Look at the iodine-only images. You could actually draw that. Okay, pancreatic cancer is a source of a lot of anxiety for residents, fellows, and even attendings because it's hard to see. You're solving a lot of issues for patients by doing this. And it's important to see the tumor because you don't want to send a patient to surgery who shouldn't otherwise get surgery because it is a very morbid and high mortality disease. So imagine you send a patient to surgery because you said, it's probably about 7 millimeters to a centimeter. They go to surgery, first follow-up, 3 months later, they have a hepatic lesion, a metastasis already. We did not do that patient service. But if we can stage the tumor appropriately, which dual energy CT would allow you to do because you can see it better, then those patients don't undergo unnecessary exams. You can say the same thing about hypervascular lesion. Here's a lesion that's brighter than the background pancreatic parenchyma. Yes, you can see it here, but look how much more accentuated. This thing is like 4 or 5 millimeters. It's a neuroendocrine tumor. This thing secretes hormones. This thing causes the patient a lot of symptoms, diabetes. It could cause GI ulcers. Okay, this little thing right here. All right, it's less than a centimeter, and this is what we're trying to detect because we're trying to tell the surgeon the thing that's causing all those symptoms because this thing's secreting hormones, you got to go and resect. Well, where are you going to resect? You can't take the whole pancreas out. That's really morbid, right? It produces insulin. You can't take the whole thing out. So we got to tell them exactly how much to take out or just enucleate that thing, just scoop it out. And then the iodine-only image, again, makes the lesion conspicuity better. Again, the projector is not doing it justice. All right, improved visualization. What do I mean by that? Let's stick to pancreatic cancer. What we showed here at Stanford was that patients who have perineural invasion and duodenal invasion don't do well. This is what this is supposed to show, okay? But just take my word for that. The other thing about pancreatic cancer is a lot of radiation oncologists like to treat it with radiation. Well, if the pancreatic cancer is invading the duodenum, they don't want to give radiation because it can lead to GI bleeding. Here's the kicker. The only way, traditionally, that we've known whether or not a tumor invades the duodenum is if the endoscopist goes in with a scope and looks and says, oh yeah, look, it's invading the duodenum. But what they can't tell you, and they can only tell you if it's invading the duodenum if it's frankly going through the mucosa and protruding into the duodenum. But if it's just invading the duodenal wall, they can't tell you that it's invading the duodenum and those patients are still at risk. So just know that there are limitations with what an endoscopist can do. But with dual energy CT, this is a traditional image, this is a low KEV image, and this is an iodinal image. There's a tumor in the pancreas, and look how it extends towards the stomach and the duodenum. It's more apparent on the low KV image because we just bring out the contrast, and the iodine makes it easy, okay? There's no question this thing invades the duodenum. This is a red flag to the radiation oncologist to say, please do not treat this with radiation. They are going to bleed, okay? Perineural invasion, as I mentioned, one of the things that we like to do about staging these patients is to tell surgeons and oncologists, hey, is there any tumor around blood vessels? If there's tumor around blood vessels, they should not be going to the OR. Here's the traditional image, and you can say, yeah, I see some haziness. Well, is that really tumor? How much is it? Not so sure, and I guarantee some radiologists may not catch this. You go to the 50 kV, look how much more it's well seen. You go to the iodinal images, and it's quite apparent. This makes life easier. Instead of now having to try to spend 5-10 minutes figuring this out. By the way, 5-10 minutes to figure out a big life-changing decision. I could just skip and go straight to the iodine image and say, yep, you know what? Guess what? This patient's not resectable. So it saves time. And when we talk about, oh, this is longer exam time, it's longer for the radiologist. No, actually, it's not. It's actually quicker for the radiologist. And when you look at the economic impact to us as a society, if you're able to make these calls without having to say, well, I'm not so sure, we're going to get an MRI, or you have to go on and biopsy. No, I can tell you right now what this patient staging is. We're saving the patient and society a lot of anxiety and a lot of, quite frankly, healthcare dollars. Okay. Let's talk about improved lesion characterization. I said one of the things that dual energy CT can do is reduce beam hardening. You can see again on that phantom how these two rods look nice and perfect. There's no streak, right? You see the streak here, it kind of goes away. So beam hardening correction. This is what happens to us all the time. So this is a patient who, let's say, came in for abdominal pain. Okay, this can happen today. You can see this patient on the flash today, for example. They get scanned for an abdominal pain. They get contrast, portal venous phase only, right? Of course it's portal venous phase because it was for rule out appendicitis or rule out diverticulitis. We're not doing anything else. But it ends up to have this lesion, this little tiny thing in the kidney. Well, this one, maybe a cyst. This one, maybe a cyst. This one, I'm not so sure. Is that a cyst? It looks pretty dense, but, you know, it could be a hemorrhagic cyst. Maybe there's some blood in it. I don't have a true unenhanced acquisition to compare to say, well, how much of this attenuation was already there before we administered contrast, right? And so now the radiologist is left to say, well, if I don't have any prior exams, I don't know what this lesion is, and I'm worried because it shows high attenuation, 40, 50 attenuation. Maybe it's an RCC, and they wouldn't be wrong by calling it an RCC. And therefore now this exam has generated what happens all the time in radiology, which is you see an incidental finding and you got to do something else. So this now requires either an ultrasound or an MRI. But that also means now the patient's going to read the report, they're anxious, they're going to wait, might have kidney cancer, that's what's going on in their head. The referring physician can't do whatever they were going to do as far as treating something else. They have to say, well, I got to work this thing up. So you see there's a lot of downstream effects when you aren't able to confidently make a diagnosis. So how does dual energy CT help? Well, it can characterize these incidentally found cystic renal lesions. We can actually characterize even more complex renal masses. And we can actually subtype the different types of RCC, which I'm not going to go into today. And then there's a role for radiation dose reduction. So another example of the same thing. Look at this, 24 Hounsfield units. By most conservative measures, that thing is not definitely a simple cyst, because simple cyst should be at least less than 20. Some argue it should be less than 15 Hounsfield units. But attenuation measurements are subject to a lot of sort of variation and confounders, because if there's a lot of iodine around something, we know that the x-rays are blocked by that iodine. So if you look at this lesion, look at that renal cortex. That thing is enhancing pretty brightly. There's a lot of iodine in that renal cortex. So it is basically blocking a lot of the x-ray photons that are going to the cyst. So you see being hardened. If there are ribs in the way, the more central the lesion, we know about this. This is called pseudo-enhancement. It's showing a spuriously increased attenuation. But if we have dual energy, we can say, well, let's put an ROI on this thing and see what it does on the curves. And that's what I'm going to show you next, okay? So here you go. Here's a patient with multiple lesions, okay? 24 Hounsfield units, just like that one you saw. 17 Hounsfield units, 61 Hounsfield units. This one's pretty simple, but it's got a little nodule that shows 68 Hounsfield units. I don't know what that is. Well, this one's 17. That's probably a cyst. This one's clearly a cancer because it's 61 Hounsfield units. It's got some mural nodularity. What about this one? I'm not sure about this one. It looks cystic, but it's got a little nodule. Is that blood? These things, even simple renal cysts, like to bleed. And what about this one? I have no idea what this is. This is a proteinaceous cyst, a hemorrhagic cyst, or is it an RCC? Here's an iodine overlay. Okay, and again, this projector is not helping us. But if it's bright, if it's got iodine, it's going to give it a nice color. And you can change the color scaling. But in this case, the brighter it is, the more sort of hot iron it is. It's got contrast and it's got vascularity. This one clearly has vascularity. You see all that iron color here. You see that mural nodularity here. So these two are surgical lesions. Simple cyst. This one, simple cyst. Okay. So if I have a patient, and sometimes we have patients with like 10 lesions bilaterally, forget trying to figure it out here. But let's say I even had the true unenhanced exam. Forget trying to do the post-con attenuation and the pre-con attenuation. Just look at this. And within a matter of seconds to a minute, you can figure out which is abnormal and which is not abnormal, okay? Additional examples. True unenhanced, post-contrast, different patients. 25 on the true, post-contrast shows 40. This one shows 31 on the true unenhanced, pre-contrast, and then 48 on the post-contrast. So that gives a difference of 15 and 17. Most people would call this benign. Most people would call this benign. Attenuation measurements are not always accurate. Both of these are surgically proven renal cell cancers, which were better seen because we were able to actually quantify the iodine in both of these lesions, okay? So without knowing that this thing, hey, wait a minute, actually does have iodine, most people would be prone to call these benign, and they wouldn't be wrong, okay? But with iodine quantitation, not only do you have this visual assessment, you can actually put an ROI here and get the concentration of iodine. I'm not going to go over the thresholds with you guys today, but just know that you can actually quantitate the amount of iodine that's in this thing. Same thing here, okay? I'll show you guys more cases, don't worry. Just to drive home the point, I've got an ROI on the renal cortex, which of course should have a lot of iodine in it, right? That's normal. That's whatever you call this color, blue, I guess, blue-green. You've got this red one, which is on this, what I think is a simple cyst. And then you get this indeterminate lesion, okay, that's a pink ROI. What I want to know is how do these things behave at different energy levels? So this is attenuation, and this is plotted against energy level. High energy, low energy. So this one is a simple cyst, water. How does water behave at high energy? Should have low attenuation. How does water behave at low energy? Should have low attenuation. You see that curve pretty much stays flat. That's what water does. This one, the blue-green one, has iodine in it. How does iodine behave? Remember I said, as we go towards the lower kV, we're going towards the kV of iodine, so the iodine attenuation increases. So you can see the iodine curves go up as we go towards the low kV. This is why we can use the low kV, the 50 kVs, to accentuate the contrast. So I know what iodine looks like. I know what water looks like. I don't know what this thing is. Let's put an ROI on it and see what that curve looks like. What does it behave like? And you can see that curve basically mirrors water. So this is in fact not enhancing. It's not iodine. It was a proteinaceous for hemorrhagic cysts. Does that make sense? This curve at every single energy level behaves just like water, indicating that it's benign. All right, and this is just another way of explaining the iodine images that you're seeing. This is what the iodine images does. Is it in the background looks at all the voxels and says, how do the curves look? If the curves look like iodine, I'm going to make it bright or give it a color. If the curves look like water, I'm not going to give it a color or make it dark. That's it. This curve is in action is what you're seeing on the iodine images. One of the things we can do is use, we can not only generate iodine-only images, but we can also subtract out iodine and get what's called virtual unenhanced images, okay? These are beneficial because, we don't always get a true unenhanced exam. So you might find something and say, well, look, I didn't get a true unenhanced exam, but I wish I did because then I know what this thing looked like before giving contrast. Well, dual energy allows you to create these virtual unenhanced exams. And so you can see all these cases, this is true unenhanced exams on the top. These patients were also scanned with dual energy, and you see the VUE on the bottom. VUE stands for virtual unenhanced. You can see the image quality is pretty comparable here. There's studies that show the attenuation is also pretty comparable in terms that they're validated, okay? So what does that mean? How is that impactful on workflow? Well, here's your renal protocols, and this is from Duke, so we don't exactly mirror this, but here's a renal cyst protocol where you do a true unenhanced and a post-con to try to characterize renal lesions. That 2 acquisitions, let's say the effective dose is 9 millisieverts. GU protocol, which is their equivalent of TCC protocol, it's a true unenhanced, a contrast enhanced in the nephrographic phase, and then a separate excretory phase. We do a split bolus here. This is 3 acquisitions, okay? So if we use the virtual unenhanced and can get rid of the true unenhanced in both of these protocols, you've reduced the radiation dose by 50% here and 35% here. Okay? That's how you're able to reduce the radiation dose. But even if we didn't reduce the radiation dose this way, if you just compare apples to apples, it is still single energy equivalent. And here's why. Take, for example, remember I said the Siemens scanner has 2 X-ray sources and 2 tubes. You're not scanning the patient with both X-ray sources and tubes 360 degrees. Remember, we do helical CT. Within a quarter of a rotation with both sources on, you can acquire the information that you need. All right, the 80-140 switch that the GE does, as you're imaging the patient helically, you're going back and forth between the two. And so, on average, it's about 100, 120, or 140 kV depending on the patient size. Okay, so it is truly single energy equivalent. We do measures to try to make a single energy equivalent. For example, in the GE, we use iterative recon. On Siemens side, we do the 2 current modulation. So there are other ways, but I'm here to tell you it is single energy equivalent, and we'll have some more talks focused on that. This is proving my point. This is the literature showing when you compare dual energy to single energy, whether it's the dual source platform or the single source platform, RS stands for rapid switching. So it switches rapidly between 80 and 140, as I mentioned. The difference is not much, okay, between the dual source and the single source, okay? You can just look at these numbers and come across and say, okay, these are pretty equivalent. But you know what? Who cares if they're not equivalent? I hate this argument because you're saying we should give dual energy CT should be the same dose as single energy CT. Well, that's not really fair, right? Because with dual energy, you can get quantitative information. You're getting more information. My father taught me a long time ago, nothing is free in this world, but yet we expect that for this. So just keep in mind, this is an argument that we try to do to make sure that the referring physicians aren't upset, the patients aren't upset, and the public. We know that the radiation dose, this is not a big difference, number one. And even if it was plus or minus 10%, not a big deal. You're getting so much more information, and you're preventing the patient from having to get additional workup that is even more costlier, okay? So I don't want you guys to worry about the radiation dose. Other examples that I'll go over quickly, and I'll turn it to Lior. We see this as well. Just like in the kidneys, where you see renal lesions and you're like, well, I don't know what they are. Same thing happens in the liver. Okay, you see these small little things. Right? This is probably a centimeter in size or even less. Now, quite frankly, you know, if you read our reports, you know what we say about these things? Too small to characterize. Constantly. Multiple, too small to characterize. Hepatic hyperdensity. Too small to characterize. Too small to characterize. patient reading that report like, what the hell does that mean? I don't know, do I need to worry about that or do I need not to worry about that? There's even more confounders. If the patient has cancer, yes, they're too small to characterize, but is it a met that we're catching early on? Remember, we're scanning patients a lot these days, right? We follow them, and so it is very typical for us to catch a hepatic metastasis early on in its infancy when it is maybe that small. So dual energy CT can actually help. This is a 79-year-old male with a known colon cancer and has 2 of these small lesions. The patient was scanned for the first time. There's no prior imaging, so we have no idea if this thing is stable. And the radiologist says, I don't know what these are. The patient has colon cancer. Before they can get treated for their colon cancer, i.e. go and get a colon resection, we need to make sure these are not met. Because if they're met, you change the treatment. The patient has to get chemoradiation. I got to go to surgery. So you get an MR. So they had to wait, delayed the surgery, patient anxiety, got an expensive MR. These were benign. Okay? That's not a fault of ours. How do you tell? You can't put an attenuation on this thing. There's no attenuation characteristics that will reliably differentiate benign lesions from malignant lesions using attenuation. We know this, okay? Dual energy can help. We did this study. This is now coming out in AJR. We showed that attenuation is not reliable, but you can quantify the iodine and you can reliably separate malignant and benign lesions, okay? So we found that if you use a threshold of 1.2, you can separate what's bad and what's good. This lesion, for example, again, this lesion looks, what? A lot like the last one. It's tiny, it's hypodense. The margins, I don't know. They're both sort of similar. I don't know that they're very well defined. The one on the right is a little irregular. This one maybe is a little irregular here. So you see what I'm saying? There's a lot of overlap in features. That previous case was benign. This one happens to be malignant, and when you use the iodine quantitation, you can see that it clearly is above 1.2, okay? There's a lot of cases that we showed in this paper where the iodine had a higher sensitivity and specificity where traditional attenuation fails, okay? It quite frankly fails. Here's a patient. Use this as your sort of single energy equivalent. It's a patient who's undergoing liver screening for hepatocellular carcinoma. So here we are trying to make sure this patient doesn't have HCC. Remember, we always see incidental findings, or sometimes we miss things because we're so focused on the primary diagnostic test. In this case, the patients make sure they don't have HCC. If we look here, the kidneys still look a little asymmetric, but if you look at the color images and the iodine-only images, you can really see that while this kidney has a lot of iodine here, a lot of iodine in the cortex here, man, it's not that same appearance on this side, right? You guys can appreciate that these renal cortices don't look the same. Same thing on the iodine images. This is easier to see. You have to take my word for it in here. We have hindsight bias now because you've already seen it here, so you can't appreciate that this is easier. But it does accentuate the differences. This is a patient with an infection of that kidney. Left untreated, this patient could go to fever, leukocytosis, even sepsis. We wouldn't have a cause. And they'd have to come back to ED. White counts jumped, and now their infection has progressed more than it should have. We catch it here. We call and say, hey, there's no HCC. By the way, they have an infection. Can you put them on antibiotics? Outpatient treatment done. Okay, so we're helping the patient in many ways by doing this. Most dual energy users will try to read these images, or I myself read these images before I use the conventional images because things pop out faster, like in this case. Obvious renal cell carcinoma. Okay, this is iodine images. These are the color overlay, and you can see clearly there's color here, and it is bright. There's no question that this thing is an RCC. This patient was not undergoing imaging specifically for this. This is an incidentally found RCC. A lot of the RCCs we find are incidental, okay? I love this case, and I'm going to wrap it up here in a second. 2 lesions, don't know what they are. Okay, they're both in the left hepatic lobe. This one's on top of this one. This is at a higher level. This is at a slightly lower level. Look at the household attenuation, 37, 9. Okay, so we think this is a simple cyst. 37, I have no idea what this is. This is a young female. Ends up undergoing an MRI to prove that this was also benign. It was just a cyst with some protein in her blood. But look, we can quantify the iodine in this. If we had dual energy in the iodine-only images, you can see that they're both dark. And in fact, the iodine of this lesion is less than this lesion. We know this thing's a cyst, and the iodine is lower. If we had this at the time of our initial diagnosis, we would have spared her the anxiety from knowing that, you know, you've got a lesion in your left hepatic lobe. It could be a biliary cystadenoma, which is a pre-malignant lesion. I mean, it's something that you want to be, this helps the radiologist more confidently characterize the renal lesion, and we would say the anxiety and the patient workup. So there's a theme here. As I mentioned, life is easier with dual energy CT, and that's what my task has been, and is going to continue to be, to try to convey to everybody, referring physicians, you guys, and my colleagues. This is a patient, we see this all the time, who's undergoing, again, ACC evaluation that has cirrhosis. And we have to figure out, we have to find all the lesions. This is triphasic, arterial on the left, portal venous in the middle, and delayed on the right. We have to figure out everything that enhances, whether it has washout, whether it has capsule. Because we got to then say, is it worrisome for ACC? And we got to give it a classification. Yes, there's arterial enhancement, but no washout. Or yes, there's arterial enhancement and washout, but no capsule. Or yes, there's all three. And by the way, what you call and what you detect has implications of whether or not it's truly an ACC. If you just look, yes, clearly there's arterial enhancement. Yes, clearly there's a rim of enhancement, that's the capsule. And yes, clearly there's washout, i.e. it's darker than the adjacent hepatic parenchyma. In 3 seconds, I can tell this referring physician and patient, this is without a doubt 100% hepatocellular carcinoma, okay? Future of dual CT lies here. Right now, the way we measure whether or not patients respond to chemotherapy is making bidimensional measurements. This patient has a lot of liver mets from a neuroendocrine tumor. And in order to figure out whether or not these things on follow-up imaging have responded, we just take 2 or 3 of these and make measurements, okay, perpendicular to each other. But look, they don't all look the same, right? You can see this is a little bit homogeneous. This is kind of dark, but whatever. We don't account for that. Right now, we just say if they're bigger or smaller and go, yes, the patient's stable or doing worse or doing better. But if we have iodine-only images and the color overlays, so this is an iodine-only image, this is color overlay from dual energy, you can see that this one still has some iodine in it. This one has undergone necrosis. You see that? This one still has iodine in it, still vascular. But this one's a lot darker than this one, and this one, and this one. This one's dark too, indicating that these 2 lesions have shown some response. So maybe it's not take this patient off their treatment. Maybe they're partial responders. And this has a lot of information that the oncologist would love to see. Okay, right now it's not possible with 5-dimensional measurements. A lot of other applications I didn't talk about, MSK, gout. Okay, a lot of value added there. Hepatic with iron quantification, bowel imaging to detect ischemia. This is where the flash scan is going to be helpful. And then the low-level hanging fruit is renal stone composition, which I didn't talk about either. Okay. In conclusion, a lot of clinical benefits due to its inherent properties. I didn't talk about everything. I want you guys to know that what you're doing and when you're scanning in dual energy mode, I want you to know what the downstream effects are. It's important that the workflow is optimal, not only for us, but for you guys as well. It's got to be easy for you guys, and it's got to be intuitive for you guys, okay? And there's a few things that you should know. Patient centering is critical, making sure that patient's appropriate for dual energy, and quite frankly, dual energy should be the default. If you know that these are the advantages, why wouldn't we give the patient this benefit, right? I'm going to stop there. If you have questions, I'll stick around at the end, but I'm going to let Leor talk about workflow. And I'm giving you 8 minutes, Leor.
Thanks. So that was really great. What I want to focus on specifically here is I'd just like to go over what we're spitting out from the Siemens systems and the GE systems. And then the workflow that we're going to focus on today is mainly the Siemens system, because we've successfully integrated the outpatient forces as well as the outpatient revolutions. We've actually had this technology for a long time, since it first came out, but we haven't deployed it because the workflow issues associated with it. Everything had to be done by hand, and it would take 45 minutes to produce what we can do now in seconds. Or what you guys can be able to produce right now, even without touching it. And so that's what we're going to go over today. This is the Siemens Advanced Recons that we're doing with dual energy. We have a 50 keV, which is the one on the left, super bright. We have that iodine overlay. So you take all of the iodine, then you overlay that on the mixed image, and the red indicates that there's iodine. So if it's yellow, then that means there's lots of iodine, and if it's dark, it means there's less. And then a virtual unenhanced image as well. So some people call that a VNC, a virtual non-con. GE calls it a virtual unenhanced. Those are kind of the same thing. This is what we're going to be doing on all of the Siemens systems. And right now we're starting off with just body imaging. So this applies to oncology as well as trauma. On the GE, we're using the Revolution. So we have that 50 keV. That's that super bright pulmonary artery on the top. We have that iodine with water, so that's not overlaid, but that's essentially all of the iodine exposed, and a virtual unenhanced. So we produce those all the time. One of the main benefits from the GE is the metal artifact reduction technique, where we can do a really good job of being able to see a lot of really cool musculoskeletal and spine work. And so we're actually, in the future, going to be optimizing our order code so that if somebody specifically asks for metal artifact reduction, that will only be going to the Revolutions, which have the superior artifact reduction software. There's no increase to dose for using any of these guys. So I want to focus on the workflow for the Siemens, specifically for the flash CT, where we only have essentially 32 centimeters of dual energy field of view. What we've done is we've created two sets of protocols, and I'm showing you the protocols from the Force right now. And so in the body section, we'll have primary protocols and secondary protocols. So the primary protocols are all going to be dual energy. You'll perform your two scouts, and you'll optimize the patient center. And I can't emphasize adjusting after you do your topograms. The right and left you'll have to do before you start scouting, but once you've done that, you can actually adjust the table height with these two, either the height button or the up and down button. You can use those to optimize your patient to fit within the dual energy field of view. And here's an example of what that would look like. So you perform your scouts, and you get like these blue, purplish bars on the side, and that shows you everything that's outside of the dual energy field of view. And so using this information, you can move the patient up or down. And if you look to the image on the right, the axial image, you'll actually see a red area where the dual energy overlay is. And the target here was an abscess drain. And that abscess drain is mostly outside of the dual energy field of view. So what we could have done is we could have moved the patient over if they fit on the table. But recognize that everything outside of that is half dose on a large patient with the low KV. So it's not necessarily going to be the best image quality. So when is dual energy maybe not appropriate? Well, if you have an abscess drain that clearly falls outside, like you can see it on the scout, if you're looking for an abdominal wall hernia on an obese patient, if you can't bring the patient down, it's probably best to switch to one of the secondary protocols, one of the single energy protocols. Also, trauma entry wounds. If you have a really large patient, we can see 50 FOV, but we don't necessarily want to see that with low dose. So if you have a really big patient that's been through a lot, we really want to be able to see all of that. And so I'm just going to highlight that your DEFOV is just a little bit smaller than the 50. And this you can see on the scout typically when you're imaging. Now, it really doesn't matter what size the patient is if what you're looking for is in the middle. So you can have a 300-pounder with dual energy. If you're looking for something in the middle, let's go ahead and use it. It doesn't matter if we cut out the fat, if that extends into the dual energy field of view. In this case, we have a kidney stone, and we map out the kidney stone, and we can identify if it's iodine, or I mean, if it's calcium-based or if it's uric acid-based. And in this case, it's calcium-based, which has implications for how you would treat that. So I'm going to narrow down the list for you guys so that when you open it, you'll only see the primary
protocols.
There's a drop down, and underneath that, you'll see the secondary
protocols,
which are essentially for obese patients where that important anatomy is either outside of the FOV, or what if you have a patient that can't hold their breath? Your flash mode protocols will also be below as your secondary recon. So they're separated, so two lists. We're going to call the secondary scans obese scans or flash mode scans. They have similar dose characteristics, but they'll have that full 50 field of view. There's no changes to KVP at this point. I know that there are some options on the Siemens system, but for right now, CareDose is going to optimize MA. You just need to make sure you adjust the pitch accordingly. And we'll leave it at 90 and 150 with the tin filter on the Force systems, and we'll use 100 and 140 with the tin filter on the Flash system. If you look on the recon part, you'll actually see two X-ray tubes that are pointing at the patient. That's indicating it's a dual energy scan mode, as well as you can see you have dual energy tube A and tube B. Another interesting thing on the recons is we have 8 recon boxes on the Siemens system, but you can actually allocate 3 different recon types. You can do tube A, tube B, tube A and B, and then you can also do a mix, also known as a fast DE, which essentially just kind of gives you a combination of 50% high, 50% low, or you can adjust the percentages. All of the images that you're going to be creating for readout are going to be this FAST-DE mode. The ones that we're actually going to be using through single via are the AB recons. And so essentially once we select the auto transfer to the AB, I've written into the system to go into single via and pop out mono 50s, iodine overlays, and virtual unenhanced images. So we have another server that's going to do all of this work for you. All you have to do is kind of follow the scan protocol. This will automatically send to single via, not to PACS. It'll trigger this workflow, and those images will then get sent to your PACS system. One last thing that I think is really, really important is that we need to be mindful of the tube conditioning and performing our warm-ups and calibrations. In general, every 2 hours, you're going to need to do a calibration if your system is not in use. And it's typically not a problem if you're only using one tube. Tube A, for example, we use every 2 hours, and so it's kind of always warm. So as long as we do our daily checkup, we're fine. But with tube B, if we're only doing one cardiac mode scan every 3 or 4 hours, we need to do a calibration before. Tube B is used in cardiac mode. It's also used in dual energy. So the more dual energy we do, the more tube conditioning we will get. But unfortunately, this system won't tell us it's time to do a calibration. So if you know that you're getting a body case, what we're going to want to do is run a calibration while we're waiting for a transport. And usually those take 5 to 10 minutes.